Hello, Yua.
Hello, John.
How you doing, Yua?
I'm fine. We are fine here. Jiwan and Hussein is here also, and Fitri.
Oh, good. Okay, let me get myself off the screen here. Okay. Oh, okay. So this is going to be interesting what bin does.
Okay, this is
I'm gonna learn something here. Because I guess he's televising it simultaneously on WeChat.
yeah, he's translating, so this is good. This is very good. Then we have the same lecture, but translated for Chinese or in two
Okay.
languages.
Good. We give it a shot. We give it a try. Okay, I'll be back. Okay.
Okay.
Hi, Ben. How you doing?
Hi, John. Hi.
Hello.
Yeah, nice to meet you again. Hi, Professor Yuha.
Hello, Zubin.
Hi.
So we learned something today about televising on WeChat.
Yeah.
No,
Yes, actually.
Yeah, could you tell us briefly? We're not on the air. We're not recording at all.
Actually, we open two Zoom meeting room in China, and the
because I could probably televise that also on Neurosurgical TV. Do you know what I mean? Well, don't worry about it today. But think
Uh-huh.
about it in the future, that I can also televise the Chinese on neurosurgical TV also.
Oh, that's great.
Yeah, okay, but we'll do that,
So,
we'll do that next time.
Yeah. So this time, we have additional Chinese room, Zoom room
Oh.
that
Oh,
broadcast.
another guy, Chinese
Yeah,
Zoom.
yeah.
You
Yeah,
see,
yeah,
all
yeah.
I need to do with that,
Yeah.
they probably televise it with YouTube or just Zoom, just Zoom.
Does it mean?
Just a Zoom, yes.
Oh,
Not
okay.
here.
So it's, okay, we'll talk about that later. Hello,
Yeah, yeah.
Sen. Sen, how you doing, Sen? Oh, Sen walked away. Hey, Sen. You know Sen.
In 15 minutes.
Hi, Sen. You're muted there.
I'm here.
How you doing?
I'm fine.
Good. Welcome.
I'm with Professor Yuhua in his house.
Okay, welcome. Sen, this is also being televised on WeChat. I'm sorry, on Zoom. Another, should I post the link, Ben, on this panel on the chat, the link to get in for someone or into the Chinese? You can put it in the chat box if you want. You know, if you think it would help. Hello, Sarek. We get to know everybody here. Okay, we start about 15 minutes.
Yuha, Professor Ernest Nemi?
Yeah. Subin?
Yeah. They're already almost 300 audience in the WeChat
That's
channel.
wonderful. That's wonderful. Thank you. Thank you.
Yeah.
It's your credit. Very grateful.
I believe it would be increased after we officially open.
A lot of people wait till the last minute.
Yeah.
Understand?
Maybe the internet is
Aurora Borealis. Share.
yes. It's mine. To close. Okay.
Do this step.
哎，你好，你好，哎，好的，那我视频就不用开了。对， 我知道，我电脑已经用耳机了。你听不见我电脑声音的。
那边就主会场那边没有声音，我说话时声音会到主会场。就是您翻译的时候，主会场那边您在说的时候肯定会传出来。
哦，那我要在主会场要关掉是吧？
对，然后您说话的时候再打。
好的，我真正翻译的时候我把它静音了就可以。
对对对。
好的，好的，好。Hello, Luis.
Good morning.
Hello, Luis.
Hello.
Hello. Nice
Morning.
to see you.
Thank you very much for your invitation. How are you, Johan? I'm Dean.
I'm fine. I'm fine.
Fine, fine.
Fine. Friday evenings here, so it is good time.
Okay. Next week I go on holidays.
Yeah.
Ah,
Yes, but by no far from Madrid, only 1 hour.
You can travel there.
Yes, no, I don't go to Mallorca. No, stay home in Madrid.
Okay. Okay. Okay.
How is China now? Is okay?
yeah.
I just read there is a big floating water floating
Yes,
in
yes.
Hubei and several eastern cities.
Yes, los monzones. The name is monzon.
And there has been raining a lot, so it's floating.
Yes.
Yes. In Madrid, 34 degrees Celsius.
It's very hot. Yeah.
It's very hot.
Very hot. It's summer.
那是对的。
Yuha,
Yeah. Luis?
and Vince, I changed my presentation to the dural fistula. It's better.
It's okay. It's okay.
It's only 15 minutes, a special case.
Okay. Good.
Okay.
Oh, Subin agrees.
Crazy case.
Mhm.
like a hernes near me.
Yeah.
Hey, Louis.
Hello, John.
How you doing? Yo cambie su titulo.
Yes.
Tu son gran dolor. Tu son gran dolor.
No, I think it's más pretty.
Tu has visto, tu titulo es más grande que el de Yuha.
Ah, because
Yo voy a decir a Yuha que tu pregunta para hacer más grande.
no.
No. Okay, 5 minutes, Yuha.
Yeah, it's okay.
Louis, we're televising, thanks to Ben, we're televising this also in Chinese simultaneously.
Yes.
I
Yes.
no entiendo exactamente qué hace, pero está usando WeChat también para televisar en chinesa. Ben, you're not translating, right? It's someone else.
No. I will translate by myself.
Oh, really? Wow.
Yeah.
Boy, you're
So
gonna be a busy guy.
Yeah. So after you have begin his presentation, I will mute myself
Okay.
in this computer, and I will use my cell phone to translate.
Well, I was going to suggest that. That's good. I mean, it's simple.
Yeah.
It's simple,
Yeah.
and I think it's going to be effective.
Yeah.
But we'll see. We'll play with it. We'll do different stuff and come to the best possible outcome.
Johanna on paikalla myös. Tervetuloa.
Sarif, you're being featured there on the main page.
Yes.
Where are you from, Sarif? Where are you from?
I originally from China.
Oh, okay.
Ah.
In China now?
Yes. No. I am moved to Kazakhstan last year.
Oh, okay. Welcome.
Okay, welcome.
Yes, my family is living in Kazakhstan, so I migrated to Kazakhstan last year.
Okay. Welcome.
I've been there, yeah. It's nice.
Professor Yoha, how you been there?
Of course. I've been
Oh.
many countries.
Yes, I heard.
Kazakhstan, Uzbekistan, and Turkmenistan, Kyrgyzstan, I've been, yes.
5 stars.
All the, how do you call, Middle Asia.
Central Asia, yeah, exactly.
Yeah.
Welcome next year.
Yeah,
This
thank
year,
you.
because of
This
COVID,
year,
COVID-19,
we are locked down
yes.
heavily.
Yeah, heavily infected.
So 1
Okay,
minute?
Yeah, 1 minute, you are.
Yeah.
Greetings, everybody. I haven't started yet, but I'm going to put the YouTube link to the channel where you can get a copy of this webinar. Yeah, if you subscribe to the channel, you automatically get that link.
This one? No. Wait.
Now, where's Joanna? We're going to have to wait till she gets here.
She was there. Johanna was there.
Oh, she's here? You're here, Joanna? Oh, I didn't see her.
But I saw her name there.
Because we can't start without her. Let's see. Okay, you ready? You ready? You are. Let me hold on. Let me get ready. Let me get ready here. Okay. Okay, you ready, Yuha?
We are ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Hold on. 1. Good afternoon. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have an episode of Yuha Neurosurgery Grand Rounds, and we'll let Yuha take it away. Welcome, Yuha. It's all yours.
Thank you. Hello, everybody. Ni hao. So I will speak this evening about surgery of distal anterior cerebral artery aneurysms. In the regular speech, we are talking about pericallosal artery aneurysms. I was working earlier in Helsinki, but after retiring 5 years ago, after many steps around the world, I moved to China and now have been here 2 years at Provincial People's Hospital. Well, I have to give always credit to my teachers. This picture is from Chicago, 1988. You can see Professor Yasakil, 63 years old here, and Professor Charlie Drake, 68 years old. Look at those guys. They are still interested learning, studying the anatomy of the brain. So this means that to learn anatomy needs more time in our life. And we have to be grateful to our masters. The picture with several persons is from Helsinki life course. This is the 2 students of Professor Yasakil. The other picture on the left is from Istanbul 2 years ago. So we are standing on the shoulders of our teachers, and this is very important. We have to give credit to them, and we can begin where they stopped. So we always make better than our teachers. This is my experience. I'm coming from Finland, and I have been working in 2 places, in Kuopio, the upper arrow, in the middle Finland or eastern part of Finland, small city, and in Helsinki, 18 years as a chairman. So we have good databases on aneurysms from these 2 centers, and these databases have more than 17,000 patients with more than 22,000 aneurysms, and out of these, more than 700 are pericallosal or distal anterior cerebral artery aneurysms. You can see also that surgery was done very early in Finland, so in 50s already more than 400 patients were operated on. So there's some differences as compared to bigger countries, patient selections. So there's only 1 center taking care of the patients. Helsinki was taking care of southern part of Finland, so all the patients are coming to 1 center. This means there are no selection biases. We have to take also poor grade patients, and this is the difference from metropolitan centers. So only 1 center. This is important principle, so we know the fate of the patients, and all the patients are coming to us. And one of the specialties in a small country like Finland with 5.5 million people is the perfect follow-up. So we can follow up the patients years, and we know also the cause of death in every individual in Finland. So the Finnish Neurosurgical School was trained in Sweden, and this is the grandfather of all European neurosurgery, Herbert Olivecrona, working in Stockholm, Sweden. He died 1980. He was the man who operated a lot of tumors, but he also made first aneurysm surgery 1932, resected the giant vertebral aneurysm, and he was the first man in the world to operate on cerebral AVMs. And 1954, he and his students both operated on a basilar bifurcation aneurysm successfully. And this is like a miracle to do without microscope that time. So these are the grandfathers of the Finnish neurosurgery. Arno Snellman, the first neurosurgeon, began 1932, and his successor, Af Björkesten, whom I have also met when I began my residency. So one of the first papers coming from Finland on aneurysm was on pericallus artery aneurysms, 1950s. There were around 10 cases, and this is a very special series because they could operate on these cases with that time very primitive methods. Professor Snellman, one old nurse, told me he was always saying, "I cannot see light." And take a look on this operation room from 1950s. So you can see a lot of light was brought there to help the surgeon who is beginning preparing surgery for a child with brain tumor in this case. So to ligate aneurysm was primitive that time. Here is a giant aneurysm, is tied with silk and then added Olivecrona silver grip on the base. So these are the distribution of different aneurysms in Finnish material in our large database. You see that the middle cerebral artery aneurysms are the most common, but pericallus artery aneurysms are also a Finnish specialty. So usually this is a double frequency for other series. So we speak about that now, and I show from the PhD pericallus artery aneurysms. Dr. Martin Lehecka had his PhD on this big number of cases, 2009. So you see here Professor Robert Spätzle as opponent. This is Martin Lehecka, and this is me, and this is my successor Mika Niemelä. And before the dissertation, I'm preparing patient for pericallus artery aneurysm. This is Spätzle, this is me, and prepare to go to clip the aneurysm. And next, after surgery, so I'm discussing the surgery to Professor Spätzle, who told that he couldn't understand the anatomy because he's operating the patients in a lateral position. And take a look on the time. We clipped the aneurysm already. It is a little bit after 9 o'clock, so took less than 1 hour. And this is the PhD of Dr. Martin Lehecka, 517 distal anterior cerebral artery aneurysms, and it was had the first time a clinical PhD book got the prize for the best PhD in Helsinki. And after that, Dr. Lehecka went to India, Kolkata, and here you see Dr. Lehecka, here, the tall man, and his future wife. And this is a great aneurysm surgeon, Professor Robin Sengupta, and this is the city major of Kolkata that time. So speaking now really about surgery of pericallus artery aneurysms, so you have to assess how is the patient, what is the grade of the patient, state of the patient, if the patient have intracerebral hematoma, what is the site and size of the aneurysm. We usually speak about low proximal aneurysms, low pericallus aneurysms. Then you have three different types at genu of the corporis callosi, and then you have the distal ones. And which type of the aneurysms? There are few cases which are fusiform, and some people speak about traumatic aneurysms. I have never seen ruptured or unruptured aneurysms, and how long, what is the length of distal anterocerebral artery, and then you have to think about possible wall qualifications, calcifications in the wall, and how the parent vessels are coming. One of the principles of my surgery and the best recommendation is that the head is high above the cardiac level. This means reduced bleeding, and you don't reserve any blood usually for these surgeries because it is clean and fast surgery. Positioning once more, head elevated clearly above the cardiac level. I have operated all cases around 300 pericallus artery aneurysms in supine position, like also other surgeons have done the other 400 cases. Park bench position is used by several neurosurgeons, including Professor Robert Spetzler. Surgical strategy: head high, and head should be straight if you operate on supine, and you should have a comfortable working angle. And when looking at the book of Dr. Lehecka, you see there are different distal anterocerebral artery aneurysms. There are the proximal ones here, and then you have below genu corporis callosi, we call them infragenu, then here pregenu and supragenu pericallus artery aneurysms, and then you have the distal ones here, distal in the middle of the corpus callosum. And many times these aneurysms have double pooches, they look like Mickey Mouse. And once more, I go back. You have, of course, when you go to this aneurysm, you have to tailor your approach. Different parts of the head, you will see in the videos coming. So the frontal flap is tailored, and we have to have access to the interhemispheric fissure. When opening the dura, you have to save the bridging veins, and very few, very proximal distal anterocerebral artery aneurysms at A2 can be done through lateral supraorbital approach or pterygoidal approach. One thing is here important: they might be rather difficult to find, and you have to do serous rectus resection. Generally, all the distal anterocerebral artery aneurysms are difficult to find, localize, because there are no real landmarks. Once more, they might be difficult to find, and when you don't have much experience and you have navigation, so use navigation to find them. You will be surprised how difficult it might be. And the clue to find pericallus artery aneurysms, you have to find corpus callosum. Corpus callosum is white. Singular gyrus is gray. And this is important. It sounds primitive and stupid to tell that, but corpus callosum is white. When you see the white color, then you are safe. One anatomical important thing in pericallus artery aneurysms, that callosum marginal or other artery is coming from the base of the aneurysm. You have to avoid occlusion. You cannot always use temporary clips, but it helps if you can use them. to occlude the aneurysm. Intraoperative rupture is possible. Speaking about ruptured aneurysms, this is more frequent than other sites because you are coming from the direction of the bleeding point. And my teacher, late Professor Charlie Drake, called these malignant aneurysms because frequent rupture, intraoperative rupture. These aneurysms have a rather broad base in relation to the artery size. Pericosal artery is rather small, but the base of the aneurysms is rather large in relation to the artery. As mentioned, they have many times Mickey Mouse figure, 2 or even more budgies, and these are usually small aneurysms. Giant aneurysms are extremely seldom. There were only 2 in the 517 cases of Dr. Lehetska. And then one important thing is that they are associated many times with multiple aneurysms. Most common aneurysms are middle cerebral artery aneurysms or other side of the distal anterior cerebral artery aneurysms. So if you see pericosal artery aneurysm, check also the other vessels. So we go now to videos. This is edited by Daniel Kosurev, Russian neurosurgeon working in Russia now, Israel now. Here you see Mickey Mouse aneurysm a little bit below the genu corporis callosi, and this is supine position, Sugita frame, and then incision, curved incision, a little bit modified according to the hairline. The flap should be large enough because you may not cut the draining veins. So you have to take care of the draining veins, and it might be that the draining vein is exactly in the middle of the opening. So you have to tailor on the other side. Here I have a small tear in the sagittal sinus. I suture it, and then I go in the midline. See, this is Kamiyama scissors I'm using here. They are good, but break easily and are expensive. So this is unruptured aneurysm, so the anatomy is more clear. We go deep, and what is our goal? To find the corpus callosum. Corpus callosum is white. This is very important here. Now we see already the aneurysm here with 2 more strong wall and then very thin wall. We put the pilot clip. This is the first clip. You should not be happy with the first clip, but check carefully. I'm using a lot of bipolar coagulation to reduce the aneurysm size. There's different opinions, but this one I have learned from Professor Yasakil, and it has been used since Dandy made his first aneurysm operation. It has been used already at that time. You see also that I was using in Finland those cottons without threads, but here I'm not allowed to do that. So dissecting carefully, and now changing the clip position. You have to take care that you don't occlude, in this case, callosomarginal artery that is coming from the base of the aneurysm. And as it coming from the base of the aneurysms, these aneurysms might be difficult to treat exactly with endovascular means, except you push a small stent inside the callosomarginal artery. The golden color clip is the temporary clip. It is good to have 10 different colors, so you know what is what kind of clip, and then carefully checking the situation. And then after coagulating down the aneurysm, you put the final clip. You see now that the aneurysm is coagulated down, and I suck it with my sucker so that the clip is taking all the base of the aneurysm. This is the final clip, and still coagulating down, killing the aneurysm. And then IC angiography shows the patency of the callosum marginal artery, and then I usually put some papaverine, and these are post-operative pictures, CT angios, 2 clips. And this is the team who made the videos. So the next case is, I think, a rupture.
Can I ask a question?
Yes.
So an excellent strategy, sir, again. So I was just wondering, since in intrahemispheric approach, you don't have proximal control as such. So in case if you encounter a difficult situation where you dissect aneurysm and you have to rupture it.
I have 7 other videos, so you will see maybe what is happening. They are very deductive, selected for this occasion. I couldn't hear exactly your question.
Okay, sir.
So,
move ahead.
Yeah, we can
Thank
wait
you.
till later to address the
Yeah.
questions. Okay.
oh, now you see that this is the
Noted, John.
ruptured
Thank you.
aneurysm.
Sorry for it.
Okay.
No, it's okay. It's okay. So this ruptured aneurysm is more tight, and there is blood in the hemispheric fissure. And now it is more difficult to find the corpus callosum. There is a lot of blood. Anatomy is disturbed. But now we see the white. Now we see the white color. So when you see the white color, then you are safe. Because the pericallosal arteries, distal anterocerebral arteries, lie on the corpus callosum. I'm using here water dissection to clean the field and to distend the interhemispheric fissure. But very simple said, the anatomy is more confusing. But we see the white corpus callosum, then we know we are in the right place. If you don't see the white corpus callosum, then you are dissecting the gyrus cinguli and you are making a mistake. You think that callosum marginal artery is the pericallosal artery, and then you are destroying the patient because you go on both sides, and then you suck gyrus cinguli and searching, and this is a whole day terrible happening. So now you see this is under the sucker is genocorporis callosi, and you see now the aneurysm. I think it was azygos artery in this case. Yeah, it was azygos. It is generally spoken. They say that it's very common in these aneurysms. It is not so common. It is like around 6% variant, so it is not so common. But when you have one case with azygos, then you think that these are always like that. So I have now temporary clip on the azygos artery, and I'm working on the aneurysm. Cleaning the field, Doppler, mini Doppler is very useful. taking the temporary clip out? No, not yet, but now it's coming. When you take the temporary clip out, don't take it immediately out, but open it. If it begins to bleed, then you can close it. If you take it very quickly out, then you cannot put it back because it is bleeding. So next video is coming here. It's edited by Johan Shoku, who made huge work on this 1001 videos. This unruptured case here we used since beginning of 2000. We began to use only CT angiography, so all the operations were done based on CT angiography, and the pictures were good. So opening the dura and the microscope to see the veins better. We tried also ICG to see the draining veins, but the dura is covering them. So you see, this is unruptured aneurysm going inside in the interhemispheric fissure. I go always on the right side, except as early operation, like we will see in the future videos. I go always from the right side to pericostal artery aneurysm because they are so close to each other, and I'm right-handed. Now you saw the both pericostal arteries, and we dissect now proximal direction. And now we are coming to the aneurysm. Here is the aneurysm. And we put the first clip, pilot clip, to compress the aneurysm and then began to work. It is not just clipping, it is a process to have good result in killing the aneurysm. So now you see that this aneurysm is has rather strong wall. Sometimes you operate on very strong walled unruptured aneurysm that would never rupture. So in future imaging and other methods will show which aneurysms have very weak places. So these unruptured aneurysms should be operated on, and those with very thick walls not. So here you saw the callosal marginal artery. Here, this is the aneurysm with white wall, and then checking with Doppler callosal marginal artery. This might be easily occluded if you ligate too tight. And this is the post-operative pictures, angios. You see, this is in the front of the genu corporis callosi. So next. Here are so-called de novo aneurysms. This patient had his or her unruptured aneurysm treated earlier, and in controls we saw that on the contralateral side, left side, 2 new aneurysms were growing, and now they are unruptured aneurysms. Now we go from the left side because the right side has been used. So I don't want to go from the side that was earlier operated on. So I make a new opening now on the left side. And you see there is a lot of scarring after subarachnoid hemorrhage. and early operations. So reoperations are always extremely difficult. It's completely different situation than you see in the angios. It may look very easy, but it is not. So I have to dissect here the scars to come to the pericallosal arteries in the midline. And now we see already one aneurysm. There are two aneurysms, two distal pericallosal artery aneurysms, or distal variant of this ductal aneurysm. So we have to go deeper to see the deeper aneurysm on the pericallosal artery. The other one is on the callosal marginal artery. Now we dissect in the middle of scar, and you will see now, we will see the earlier grip here. This is perfect, guys. You'll soon see that there's no recurrence. Go there. So now here. So this is okay. This is okay. Now we put the temporary clip here to deal with this thin-walled aneurysm. Put first clip there. Call it pilot clipping. And then we begin to work with the aneurysm. We take temporary clip out. You see there's a thin part here, remains outside of the clip, proximal to the clip. So what I'm doing here, I'm coagulating down the aneurysm. Dissecting it, put another clip here. It is written definite clipping. Let's see what's happening. There are two clips now. Yeah, I open the aneurysm, coagulate down. Then using Doppler, check the callosal marginal artery. You see here it has also an aneurysm here. Small aneurysm, callosal marginal artery has a small aneurysm here. So I coagulate down, but this is not wise what I'm doing now. You should not coagulate like that. You have to put temporary clip, then you can coagulate down. And put one clip, but when it is small aneurysm, it doesn't take all the aneurysm. So you have to put one more clip. Proximal, this is called double clipping. We have published it also many years ago. And now it looks good. There's a bundle of clips and papaverine, and this is post-operative angio with several clips, now 5 clips there, so giving artifacts. This is not running.
So it's not running?
Yeah, wait.
Maybe
Okay, we
start
skip it. It was
Yeah, just start it again.
no, we skip that. Oh, I can try once more.
Okay.
It's not running. Okay, it doesn't matter. So we have any. And here is a right pericostal artery aneurysm, you see that the patient had hydrocephalus, severe bleeding. In front of genocorporis callosi, the aneurysm. Looks very round, not ruptured aneurysm. Again, right anterior interhemispheric approach. And going inside here, interhemispheric fissure, a lot of blood there. Very disturbed anatomy. We operated on most cases in first day after bleeding, in first 24 or 48 hours, even on the day of the rupture. So they came directly to our hospital, and now you see that it ruptured. The anatomy was not clear, it was disturbed, a lot of bleeding, and how it is bleeding. This is what Dr. Drake called malignant aneurysm, because you are coming from the bleeding point. Here, now it means what I'm doing now. There are many clips, I'm coagulating down the aneurysm. You see that the rupture site is very close to the base of the aneurysm. The difficulty is now that I coagulate down, but even so, I don't have at the moment a temporary clip. I'm cleaning there. I'm dissecting now to have a temporary clip. And it's bleeding. Now I have a temporary clip now. Now you see there are many clips. I have tried to stop the bleeding. Now I'm safe. Now I'm safe. Take the clips out. Change the clip very close, perfect clip at the base of the aneurysm, because the rupture site caused by the bleeding or by me, by my inaccurate dissection, we have to take care of it. And now removing the clips, and you see that it's still bleeding, but now we are safe because there's temporary clip and I'm coagulating down all the rest of the aneurysm, and then now take the temporary clip out, and now final clip on the coagulated base of the aneurysm. This IC angiography shows the arteries are filling, doing well. And then papaverine on the place, and then closing with hemostats. And these are post-operative pictures. And then next case. Okay, here is the one patient who had her aneurysm coiled, but there's a compaction of the coils, and So we go again from the right side. In the fissure, we see the coils inside the aneurysm, and a large part of the base remains free. And you see also that the base is rather thin walled. So we put one clip, pilot clip there. Dissect, you see the scarring here. When you have ruptured aneurysm, many times the coils seem to be outside of the aneurysm because they go inside the thrombus. And now I take all the coils out, then coagulate down the aneurysm and clipped. So these are the post-operative pictures. And then next case. Oh, this is this is one of the giant aneurysms in pericallus artery. Aneurysms, they are very rare. This was a Russian truck driver found unconscious when driving from Finland to Russia in his truck and was brought to us. You see there is a big hematoma. He was unconscious, and there is a giant aneurysm, mainly thrombosed. It's November, cold times. You see that the brain is bulging. I open slightly only the dura to get the CSF out, and then you see I opening with my needle. I open the subarachnoid space to have CSF out and then compress. In Helsinki, there was extremely good neuroanesthesia, so even with fresh subarachnoid bleeding and big hematoma, the brain was slack. One of the things is that you have the head high about the cardiac level. Now we go to the hematoma. So suck the hematoma out. Now this gives us room, anatomy again, fresh bleeding, same day, and operation same day as bleeding. And you see the big aneurysm, giant aneurysm here. And my cottons without treats, and then manipulating the aneurysm. In this case, you have to, it is a must to have a temporary clip. You cannot manage the giant aneurysm without temporary clips. You cannot have good clips in them. So I put several temporary clips proximally and then also in distally in pericallus artery, and then also in callosum marginal artery. Dissect all the time the giant aneurysm here. Looks that there are two different age of blood, thrombosed and then black, rather fresh. Here is like some organized blood in this truck driver. Now checking the situation, we have to find all the arteries. So now there's one is in the proximally on the pericallus artery, then this is callosum marginal artery, and then we should put also here. Now we have the aneurysm isolated. Usually I take thrombus out with CUSA. This is I seldom use ultrasonic aspirator, but it is the best way. I suspect this was done late in the evening or night, this operation as emergency, so I didn't have CUSA to be used. So I take mechanically thrombus out, but this is not as good as CUSA because it gives some shaking of the aneurysm. Okay, now I took my solution first was to take 2 J-formed clips, one from other side and then the other side, from the other side, to have them at the broad base of the aneurysm. But as many times you have to change your plans. You have to be flexible in your surgery. If the solution is not okay, then you have to think about next possible trick solution. It doesn't look good. It doesn't look good. I took the debris clips out, and then what should we do now? I take the clips out and cut the aneurysm. Resect the aneurysm, leaving only a small part of the base left, and this makes we can collect then the base inside the clip. Here, it's already clipped now. Now the aneurysm is coming out. It's close to it's 1 inch or a little bit more. This is a post-operative picture. The patient slowly recovered, but of course couldn't go back to his work as truck driver. And this is from our operation room here at Henan Provincial People's Hospital. We have good team. We have to remember, no one is doing surgery alone. This looks very similar than my earlier life in Helsinki. We have good team and good instruments. And this is coming from here, from Henan Provincial People's Hospital, the last video edited by Tung-San Chen. Sorry, was not running now. So this is distal A4 aneurysm, very small unruptured aneurysm here. And the patient was bald. Patient was bald, had no hair. So I'm not shaving the patient's hair. Going inside the interhemispheric fissure, this is unruptured aneurysm. And you see there's a patty with treat. This is like retractor here. I don't like the treat. They stuck to everything, but of course they save you some, in some situations that you don't forget the patties or cottons intracranially. So now you see that this, we go, the aneurysm is attached to falx. Now you could speak and speculate it is a traumatic aneurysm, but I don't believe so much on that. But anyhow, it was attached to falx, and now we are dissecting this. As I mentioned, this has very broad base. This aneurysm is very broad base. And now a part of the falx remains there. So now I put the temporary clip. And then have coagulated down the aneurysm and checking and taking temporary clip out. But I was not happy with the clipping, so I put once more temporary clip there. And coagulate down now. With the protection of the temporary clip, I coagulate down the aneurysm, kill the aneurysm, and then put the final clips there. Take the temporary clip out. And this is the situation: clean water and good looking brain. And this is ICG, shows patency of all the arteries, and the patient made good recovery. These are the postoperative pictures. A4. Aneurysm more seldom and even more difficult to find than those located at genu corporis callosi. So these were my videos. I'm sorry that one was not running, but you saw several, and I think this was a good selection of the possibilities and difficulties in clipping the aneurysms. So finally, I want to say, please listen carefully. Don't shave the beautiful Chinese hair or other hair of other nationalities, but in China it is very common. So take a look on these beautiful females with beautiful hair. Don't take the hair out. Make focused, minimal, invasive haircut when you are doing neurosurgery. This is still Chinese practice. It looks terrible for me. Good practice. Take a look on this 10-year-old girl with parietal medium-sized AVM with large hematoma, has been recently operated on, and looks good and normal. And the ladies are very happy that they don't lose their hair. So open your mind, change your policy. It doesn't increase infections. It is minimal invasive, which is the trendy term nowadays. So I think distal anterior cerebral artery aneurysms are special aneurysms and should be clipped. Thank you very much. Kiitos. Say.
Okay, Juha, thank you very much. I just want to say we are also televising this in China, thanks to Ben Zhu. And there's a picture of the screen being televised in Chinese. So, okay, let's open up the floor to comments or questions.
So there was one question in the beginning. Maybe it was answered by the videos.
Okay, what was it? You want to talk about it? No.
There was one question after the first video.
Oh, okay.
Yeah, I think you answered that question. So my question was answered by you in video. Hi, this is Dr. Laghari John. I'm Dr. Altaf Ali from Pakistan, Karachi. It's a pleasant weather over here in Karachi right now. It's raining and it's evening time. An excellent presentation by Professor Joa. And I think I learn every day whenever I watch his videos. And my question was answered by his video, that how about the aneurysm which bleeds and you do not have a proximal control. Do you want to elaborate further, Professor Joa?
Yeah, it is. Sometimes it is not so good anatomically possible to put a temporary clip. So many times, of course, in unruptured aneurysm you can manage usually well, but it is of course very nice to have a temporary clip. But sometimes when the aneurysm is below the genu corporis callosi, it is very difficult to come without excessive surgery for proximal control. Many times it is not necessary. The name malignant aneurysm, like late Professor Charlie Drake, my teacher, gave. It was coming that you are coming. This is the bleeding point here, so you are coming directly to the bleeding point in anatomically. This is the difficult. Sometimes we have learned to handle these aneurysms. I have learned to handle them delicately, so it is seldom it ruptures. Like in one case, it was rupturing, but this is seldom situation. But
Did I answer the question?
Yeah.
Okay, I believe Hugo Andrade has a question. Hugo, go ahead.
Hello.
Yeah, hi.
Hi, Professor.
Yeah, go ahead,
Hello,
Hugo.
Hugo.
Hi, how are you doing?
I'm fine. I'm fine. You?
Excellent talk. I don't know if you
Thank
want
you.
to discuss a little bit how you find the aneurysms normally, what you use like as a landmark, like the coronal suture when and
You have to take a very good look on the sagittal picture, where to open, because it may be below the genu, in front of genu, above the genu, or distally. So you have to tailor your approach, and then take very good care of the angle of the microscope. When you look with the microscope, you may go above the corpus callosum, very far distally, or wrong direction. So take, before draping, very good look at which position the head is, and then tailor your microscope. And when you have not large experience in finding these aneurysms, then it is good to use navigation. This is very important. I don't need navigation in these aneurysms because I have done 300, but so I find them like with instinct. But I have also my first aneurysm I didn't find. I was searching all the day, and then I had to go to have angiography 40 years ago, and I'm lying now, 35 years ago. So I didn't find, so we had to do angiography. I left the clip and then went back. So it is very difficult to find. When Sukita, late Professor Sukita visited Helsinki, he was watching neurosurgery. There was another young neurosurgeon operating on pericardal artery aneurysms. So Professor Sukita said, difficult to find. The young neurosurgeon said, no. But he was searching all the day and didn't find. So it is experience that tells. And I have many stories about that. Dr. Drake also, who had published this series.
and also that I learned with you and that we always use is just a 3D reconstructions, because then we can think how the aneurysm is gonna look.
Yeah, this is very important. So in CT angios were beautiful what you did, and here also when they give effort, when effort is given, the CT angios look beautiful, but of course they are doing so much DSA here, so they don't give so much effort on CT angios. But usually for microsurgery, CT angio is the only thing that is needed. That's why we could operate every case in Helsinki. CT, subarachnoid hemorrhage, immediately CT angio, and then the patient was ready to go to operation room. And this is so fast in small hospital.
Yeah. Good. Thank you.
Okay, thank you, Hugo. Any more comments? Go ahead, Victor. Welcome, Victor, from Mexico.
Hello, how are you? It's very nice to see you, Dr. Yuha.
Hello, Victor.
Also, Shubin, it's very nice to see you from Mexico City. Dr. Yuha really was good cases, very nice presentation as usual. The technique of clipping aneurysm was really impressive. Thank you for giving us this level, this high level of presentation of these techniques. Thank you so much. It's just a comment.
Thank you, Victor, for your kind words.
Thanks, Victor. Okay, more comments, questions?
Can I ask, John? It would be a second kind of question.
Go ahead, go ahead.
So, how do you manage if you inadvertently coagulated and the vessel, like a perforator or sometimes distal here?
Yeah, then it is gone. You cannot manage anymore. If you coagulate the perforator or some parent artery, you have to be careful. You have to be careful. You should not, when you have no experience in coagulating the aneurysms or vessels, then you should not coagulate. It is not recommended. So it needs more experience. I think it makes some situation easier if you have the complex aneurysm, several putties, you can coagulate it down and then have a perfect clip at the base. But otherwise, when you have rupture of the aneurysm, then it is good to coagulate down the aneurysm. It helps you. So it is one means besides clipping.
Sir, how about your experience about intraoperative stent placement in a spasm situation where you find a spastic vessel post-operatively? Do you use intraoperative intra-arterial nimodipine or intra-arterial vasodilating agent with the help of interventional interventional neurologist or neurointerventionist, whoever is at your hand?
First,
do you have any experience?
I have a lot of experience. So maybe you really know that we operated on these aneurysms within 1 day. So there is no spasm in these cases. If we had a patient which came late with spasms, so we operated on a higher blood pressure, but it is not usually the surgical problem. You maybe didn't know that I put papaverine on.
Yeah, I noticed that. I noticed that.
Helps for manipulation. So, but otherwise we used, after operation, we increased the blood pressure high, used AAA therapy, even you can discuss about that. And we used nimodipine, even you can discuss about that. We gave all the possible means to prevent vasospasm. We didn't have so good experience with endovascular means to treat the spasm, but this was maybe our level of endovascular surgery was not that time not so high. So we had some complications and we gave up to treat spasm with endovascular means.
Okay, very good. More
our material of all the aneurysms, ruptured aneurysms, 2% died in spasm and 17% are invalidized from spasm. This is in the large material, so whatever we did.
Okay, very good. More comments, questions from the panelists?
Yes, I have a question.
Oh, okay, go ahead, Joanna.
Hei, professori Hernesniemi. Kiitos oikein kovasti. Upea esitelmä. Viikon kohokohta. Minulla on yksi kysymys. Se oli niin täydentävä, että ei oikein, se oli niin upea. I have one question. So we all have been now wondering about this proximal control because it's so difficult to reach and so difficult to gain. In case the aneurysm is really lying low and you have done all the tricks that you possibly imagine, and it's still difficult to reach. When is the threshold when you start to think to resect even a part of the genu in order to reach there? Is there some point when you select this really drastic one?
We are not resecting the genu. It belongs to the historic era of neurosurgery that you resect the genu. We are operating under very high magnifications. All the brain we are sucking away is minimal amount, few millimeters. Minimal amount. So, but so you can push the genu back.
But you never reach.
Okay. No, we are not resecting or making the callosotomy for that we can have proximal control. I think you can do going around the aneurysma, you can clip the aneurysma without proximal control. So I think in basilar tip, you have to have temporary clip.
Yeah.
Without doubt. But here we are dealing with the aneurysm. It is in front of us and there are no cranial nerves or perforators around it. So we can treat the aneurysm also with regular means.
Yes, sounds reasonable. Thank you so much. Really good. Thank you.
Welcome.
Joanna is a neurosurgeon from Finland, correct?
Hopefully becoming one.
Oh, okay.
Yes.
Okay, well, welcome. Okay.
Thank you.
I'm so thankful.
Go ahead, Professor. Go ahead. Go ahead, Dr. Mesri.
Hello.
Go ahead, Dr. Mesri. Go ahead.
Yes.
Go ahead. Hi, do you have a question or comment? Go ahead.
Professor Zuha, can I ask a question?
Yes.
Of course.
Yes, you can.
Okay.
We
Hi,
can hear
Professor
you.
Zuha. Professor Zuha, good evening. This is Dr. Uday Bhaumik from India.
Hello. Hello.
Hello. Hello, Professor Zuha.
I can hear you. I can hear you. I can hear you.
Professor Zuha, I have got a question for you regarding the high pericallosal superior to genu aneurysm. Do you always use a retractor to dissect the deeper way? And second question is, have you ever encountered lower limb weakness or paraplegia just because of the retractor based injury, because you are working in very deep cervices? And what do you suggest? Can it be done without retractor also?
I showed 7 videos. There was once retractor. In one case, there was retractor. I'm usually not using retractor, but if you have good space, I mean the brain is slack and you have relieved CSF, then you can put the retractor, but it should not push the brain. It should just support the brain. So I think times of retractor-induced brain injuries are over, at least if you read your books well and make your homework and have good anesthesia and use all the surgical tricks to relieve the pressure. If there's a strong hydrocephalus in this aneurysm, I go in the interhemispheric fissure and push my microschizo through corpus callosum, and then you get CSF out, and then you have a lot of space. There was one video that was not running at the hydrocephalus and the intraventricular clot. I pushed my microschizo through corpus callosum and get a lot of CSF. And hydrocephalus was relieved, and I left also a drain there. But I'm seldom using retractor. Yeah.
Okay.
Is that a good answer for you?
Yeah, thank you.
Okay.
Thanks for the question.
Yes. Dr. John, thank you so much for this organization, and for Dr. Juha, I'm so thankful for this. I have only one question about the genetic and genetic of aneurysm in one member of family who have this pathology. Can you clarify, please?
I didn't understand your question.
The genetic of aneurysm, of such aneurysm with family member with this pathology.
Yeah, we have made a lot of studies since 90s. Dr. Antti Ronkainen made his PhD. Professor Antti Ronkainen made his PhD on familial aneurysms in Kuopio, Eastern Finland. It was supervised by me, and then we made a lot of genetic studies, but didn't find any breakthrough in this research. It has been done 30 years in familial aneurysm. So we had 10% of the cases familiar.
Have you operated the same member of family? Have you operated twice member of family with this pathology?
I have even operated 2 brothers on the same day with unruptured aneurysms found in family screening. So it is. I have done many. In Kuopio we did a lot because of the research we found in the more than 200 families, and they had maybe 30% of the family members had aneurysms, but we didn't find any real cause. Even there were very good basic researchers doing that study in USA. So we didn't find any simple low-key genes. I don't understand so much basic research in genes, but I was part of the research group, so I got somehow infected with that. But we didn't find any reason. Dr. Juvela has found out that the most important factor is smoking in developing aneurysm, and this might be true. So this in China, 60% of the males are smoking, females not. And this might be in Eastern Finland study. So they have a big study, 30 years. They changed all the dietary habits and smoking habits, and the number of intracranial aneurysms has decreased tremendously during this population treatment.
Thank you so much.
Okay, you're welcome.
Thank you for the question. More comments, questions? Now's your chance. Okay, I guess. Okay, we'll finish up, Dr. Ernest-Niemi. Thank you very much. Thank you. Unless does someone have a question, go ahead. Go ahead. Go ahead.
Could you translate the Subin? Could you translate? Is it difficult? How you are doing now?
Yes, I'm translating at the same time. I can report to you that there's 3,178 audience are watching this, watching your presentation. Yeah.
Okay, thank you very much. Okay. Now,
okay, thank you, Dr. Ernest-Niemi. And okay, now we'll turn it over to Luis Lopez Ibor. He's going to talk about embolization of complex intracranial dural AV fistulas. Welcome, Luis. It's all yours.
Yes. Okay. Good morning, everybody, and good afternoon. And John, help me. ¿Tengo que abrir primero mi presentación o qué?
Sí, es posible.
Sí, sí. Abro primero mi presentación.
Tú vas a abrir, ¿verdad?
Sí, estoy abriendo. Un momento.
Okay.
Ya está.
Okay. No puedo ver. Necesito compartir. Compartir. Sí, al fondo.
Vale, ya está.
Sí.
Ahora.
Ok, sí. Perfecto. Más grande, eso es.
Ok. Okay.
I hope this presentation is in English.
In English, yes. I'm sorry from the.
No, it's okay. And I'm impressed by John. He knows the Spanish very well.
Okay, we got rolling.
Okay.
Yeah.
Thank
Go ahead.
thank you, John. Thank you, Professor Niemi and Professor Subin for this invitation to participate. I present my strategy, personal strategy to treat the dural AV fistula. I don't like very much the classification of the dural classification of Cognard or another, because for me the most important is why is the best strategy to treat the fistula, and that is depending of the anatomy and the multiple feeder or localization. Example, the most common fistula is the cavernous, spontaneous cavernous dural fistula. This is the MR. You are the right dilatation of the vein. This is the fistula in the right side. Also, you are a small hypertrophy vessel in the left side. This is the angio-MR. And the most important to know is this point. The fistula, you are the feeder of the internal and external carotid artery, and the venous drainage is the cavernous sinus and the coronary sinus and the contralateral petrous sinus. If you check, this is external maxillary and internal artery. This is the medial meningeal and small meningeal branch. And when you check the left carotid, you are also the participation to the fistula. And everybody talk this, no, there's a bilateral fistula. No, no, no. The fistula is in this point. This is the collateral circulation. When you are this, to treat it, the best way is venous approach. You catheterize the inferior petrocell sinus and you go into the cavernous sinus. See, still closed, it's possible to open. Most of the time, it's possible to reopen this. This is in the lateral view, the fistula. And this is the catheter by venous approach. And you're still now in the cavernous sinus. This is the ophthalmic right vein. This is the orbit right side. Lateral view, the catheter need, you are sure, still in the median part or distal part of the cavernous sinus. When you are sure this position, you see you have free, because it's dangerous to inject the onyx. Sometimes it's possible to put some coils and then complete with onyx. I put some coils. This is the contrast. This is still open. Why not to finish with coil? Because if I finish the coil, you are more possibility to increase the mass effect and have aparesia of the nerve, cranial nerve. This is only coils. First injection of onyx. Second injection of onyx. Third injection of onyx at the same time. And you are reflux and you close the fistula. More injection, more compact onyx. This is after remove the catheter. This is before, and this is onyx and coils around the siphon carotid and around in the cavernous sinus, only in the right side. Control, right carotid and left carotid, total occluded the fistula. This is the best treatment for this type of fistula in the cavernous sinus. Another example is the difficult case is the giant lateral dural fistula, the senus lateral. Is treated before with another doctor in another center, and sometimes you are many collateral circulation, induced collateral circulation. This is the pharyngeal branch, and this is posterior meningeal branch with two feeders. This is the occipital branch. This is the meningeal branch, and this part is the point of fistula. This is the old coiling or old embol with another center. When you check the vertebral, left vertebral artery, you are the same meningeal branch and multiple meningeal hypertrophy and meningeal branch. Look in AP view and look the flow going to the fistula. This is the old embolization. This is the new situation. Occipital and vertebral anastomosis going to the retromastoidal branch and going to the fistula. You have too many branches. And this is the onyx with the, this is the reopened fistula. Also, the medial meningeal branch have anastomosis. And also you are a branch, pharyngeal branch of the siphon, of the carotid, internal carotid, the anatomic variant, and we're going to the fistula. Okay, why to treat this? The first step is put the microcatheter in the medial meningeal branch more distal, close to the fistula. The second is put one balloon, long balloon, 7 centimeter balloon by 8 millimeter diameter, to create a canal in the lateral sinus, and you have the possibility to inject the onyx to close every anastomosis or feeder to the fistula. AP view with balloon, oblique view after injection of onyx. You are the canal in the lateral sinus. You are the onyx in the wall of the sinus. Total occlusion of the fistula. This is the balloon. This is the final injection of onyx. You see here the reflux in the multiple meningeal branch around the origin of the vertebral. Reconstruction of CT scanner. You are the reconstruction, you are here, the balloon position. And this is the final control, internal and external and vertebral, totally occluded this complex fistula. This is important, the balloon remodeling in the vein to preserve, if it's possible, the lateral sinus. Sometimes you need to close the lateral sinus, but if it's possible, it's preferable to prevent not occluded the sinus. This is another case, anterior fistula with the palpebral branch of the ophthalmic artery, bilateral, with anterior ethmoidal arteries, anastomosis is bilateral. This is the frontal vein, and this is the frontal sinus. Of course, this fistula is possible to treat it by surgery, but it's the first case I treated this by venous approach. This is oblique projection. This is the catheter in the sinus, and this is the microcatheter in this point to this point, and injected the onyx to fistula, to nidus, and this is the reflux, and then remove, and this is the control in the left and the right side, and total occluded the fistula. The goal is to occlude the point of the fistula. It's not occluded only the vein. This is the goal. More complex case. In the longitudinal sagittal sinus, this is a complex case because you are many feeders. This is the middle meningeal artery. AP view is cortical drainage with the left side. Also the meningeal, middle meningeal in the left side going to the fistula. This is the vein. This is the lateral view, oblique view, middle meningeal, many branch, another branch from here. Also this small branch, anastomosis meningeal. Also anterior meningeal with the ophthalmic, going every time to this segment of sinus. This segment have the many points of fistula. Later phase, it's important to know, to see the sinus, longitudinal sinus is still open. To the beginning, I catheterization the more possible distal part of the middle meningeal in this point, and inject the onyx. I prefer to use the no detachable catheter because I like to have a very high reflux, about 10 centimeters is possible. She use the detachable catheter, sometimes you are possibly the rupture of the catheter and you stop the embolization. This is the reason I prefer to use no detachable catheter when I inject the onyx in the meningeal branch of the external carotid. This is another pedicle, no detachable. AP view, you are sinus, and you are the vein, cortical vein. This is the cortical vein. This is the feeders. I inject diluted glue, high flow diluted glue, because see, you inject here onyx, you stop here the flow, and you need to go to the nidus, or proximal to the fistula. This is the goal. After embolization, I have a partial result, still some vessels, but few months later, the fistula is still open, and I decide to treat it with direct punction, percutaneous punction by butterfly, transosseous punction to going to this point and then inject the contrast, and this point inject the onyx. This is the venous approach. It's impossible to go into the vein. It's impossible to navigate to the fistula. This is the reason I use direct punction. You have the needle here, butterfly. This is the transosseous. This is the vein. AP view, AP view. This is here. Lateral view. This is the punction, the point of the punction in this part. Look that, the needle butterfly here. And then I have the flow to go into the fistula. But it's possible to have the reflux, but sometimes it's not possible to inject too much onyx. This is a case. After injection, only several drops of onyx going here, but no, still the onyx is still here. Okay, and I continue the treatment. I decide to treat it with only this way. This is the superficial temporal artery. You are many difficulty to navigate from this point. This is the late phase. This is the microcatheter in lateral view. Close to the fistula. This is before cathetericize, embolize the fistula. This is the remnant, is here. And now, one injection, three injection, total injection, totally glued, closed with onyx, this complex fistula lateral view. And the second side. Also, the tentorial fistula is difficult to treat it because you don't have too much place to navigate because you are a kinking. The goal is going to the origin of the vein. The goal is occlude this point to this point. So you're still here, you are every time collateral circulation. To perform this, I use a balloon technique to navigate, to cross here, many difficult. This is the selective injection of the tentorial branch, Bernasconi branch if you want, after embolization, but have a recurrence 3 months later. I decide to go into the surgery room and remove this fistula. Is not easy. It's not easy, the surgery in this point of the endovascular procedure. This is final control and totally occluded. A final case is a very crazy case. I think I like Professor Henry liked this case. I started treatment, the symptom in 2003. I finished 2010. All the treatment and center, many doctors, many treatment, embolization, radiosurgery 2 times, stereotactic surgery, every time the fistula is still open. But what is this fistula? It's very difficult because it's impossible to reopen the petrosal sinus. It's occluded and it's impossible to reopen. The ophthalmic vein also is occluded. This is the external carotid artery, maxillar internal, middle meningeal, temporal, superficial temporal, occipital. You are a pouch of the fistula. The fistula point is here. This is the vein. This is the basilar vein, the Rosenthal cortical, and this is the stride sinus. Letter phase. AP view. In external, you are maxillar artery, internal maxillar artery. You are the meningeal branch, the pouch of the fistula. This is the point on the fistula, and this is the vein. Also, it's contralateral vein. Cross the middle, the basilar Rosenthal in the left side. In the beginning, I need to treat it to this point, navigating the lateral, inferolateral trunk, but very, very, very difficult to navigate. Finally, 4 years later, after radiosurgery, continue still open, and finally come to my center. And I decide to treat it, but direct punction, percutaneous punction by foramen oval to cavernous sinus, the same way of the trigeminal approach of the neurosurgery. This is AP view. I place one balloon, prevented balloon in the carotid artery because I need to inject this onyx, or I have a rupture of the carotid. I have the protected balloon. This is the plain film Hertz projection. This is the balloon. This is the patient. This is CT reconstruction. And to this point, I place, this is the balloon, the catheter, this is the direct punction, foramen oval, and then I put the micro guide wire and micro catheter to put some embolic material or coiling or glue, but the problem is every time I going to cross the dura, it's very difficult. It's impossible to put the macro catheter. About 1 hour of manipulation. Only have a possibility to put the guide wire. Okay, finally I stop, and the control angio, the fistula close, totally close this fistula. Okay, it's present some interesting case. I thank you very much for this opportunity. Thank you.
Okay, Louis, thank you very much. Okay, the floor is now, let me get you off that screen share there, Louis. The floor is now open for comments or questions for Louis.
Hi, Professor Luis.
Yes.
A very nice presentation, especially the last case. can you give us some more detail about the puncture of the to the venous porch?
Yes, it's
Do
by.
you have some? Yeah. Do you have some navigation system or?
No.
Because is it? Do you worry about to puncture to the ICA?
No. I don't have. I don't have a special difficulty because it is the same way use the neurosurgeon to the electrocoagulation of the gasser. It's the same. The only difference is when you cross and you go into the gasser, I use one lumbar punction needle, and this lumbar punction I curve a little bit, and then I turn 1, 2 times, and spontaneous, one time, going to the signs. Of course, it's a risk. It's a risk to rupture, but it's minor risk rupture the dura, and major risk is rupture the siphon. And this is the reason which I put the balloon to protect.
Okay.
Okay, great. Thank you.
Very good. Thank you for the question. Okay, more comments, questions? Panel's quiet today.
Professor Luis, can I ask a question?
Yes,
John?
go ahead. Of course, go ahead.
Yes.
So this is Dr. Altaf Ali from Karachi. It's a evening time over here, and a very nice presentation. I just wonder, what is the difference of treatment in dural AV fistula and spine versus cranium?
What is the main difference with the spinal fistula and brain fistula?
Absolutely. In the intervention, the difference in intervention.
In intervention of the dural spinal fistula, the most important is to know where is the localization, no? And check see at the same level of the fistula you are origin of the anterior spinal artery. This is the only important point to check this, because if you are at the same level of the fistula, you are the origin of the spinal anterior artery, this is a surgical treatment, it's not endovascular. The second point, in the dural spinal fistula, never I use onyx, only glue, because onyx is dangerous. You are possibility to reflux. And when the Turmix, where is the main difference with the intracranial dural fistula? I think it's only the anatomy of the feeder, but the pathophysiology, for myself, at the same. It's acquired lesion, it's not congenital. Probably many hypotheses, but to discuss in another moment. Okay.
So you presume that it is an acquired lesion rather than congenital.
Sorry, repeat.
You think that the AV fistula in the brain,
yes,
in the dural AV fistula is an acquired lesion.
Yes.
It's not a congenital.
No.
Is it so?
This is true. It's acquired lesion. I published this with Las Unias in past century in 1983. It's acquired. It's a spontaneous and acquired fistula. Is not congenital. Only in the newborns, but in the normal life is secondary to microthrombosis, infection, whatever you want. But it's accurate.
问题是关于第一类就是先天性的问题，大多数的是后天的，除非在有一些
Okay, you gotta mute there, Ben. You gotta mute there, Ben. We're getting your Chinese translation.
Okay. Okay, Luis, I have another question for you. How often you use the lung balloon to protect the transverse sinus?
Yes. Okay. I think it's an interesting question or comment. The balloon is a special balloon to one company from Europe. Is a long balloon. It's Copernico. The name is Copernico. But before this balloon, I used the carotid angioplasty balloon, the Pronis to navigate. But why I use the balloon? Two comments. One comment is I like to preserve the flow in the lateral sinus because when I treated the patient at the beginning, I closed the lateral sinus. Some patients have a dementia, long-term dementia, secondary to occluded. Second point, see if you want to inject around the wall of the sinus to close the fistula, the best is to protect and you inject the onyx and you invert the flow and you are more possibility to inject a totally portion of the communication of the fistula.
Yes, I agree with you.
Thank you.
Thank you.
And finally, Professor, finally comment. I know one or two, I think it's two cases, one case of René Chapot still reopening the lateral sinus and the fistula disappear. Look this point. Why not this? It's interesting this. Maybe to reopening this is decrease the flow in the wall and disappear the fistula because you know you are sometimes the dural fistula is regresses spontaneous. Sometimes. Juha, what do you think about the fistula? Is complex to surgery?
I have done many, but this field has been nearly totally taken over by endovascular surgery, and it is maybe good because I made maybe 200 of dural AV fistulas. Dr. Anna Pipo made her PhD on these cases, more than 200 patients in Helsinki. So many of those were very difficult surgery. Those at the lateral here, they were the most common, and opening was the most difficult thing. So I think this is more elegant now with the endovascular surgery. There were in this series or later there were two cases which all the time developed more and more fistulas, and one of them looked very similar. You have treated in the long row of them. I think Professor Moret was involved in one of them, and I was treating the other one, and they were like beginning to speed when we treated, and next time we made controls, they were looking more and more terrible. So I got the impression that there must be also something you could do some with some general medication, or it is maybe not. There must be some kind of angioproducing factor angiotensin, angiogenetic factor in these cases. So you might influence them with other means than surgery or endovascular surgery. But until now, we didn't find out. So I think this will be the future, maybe, to inhibit the development of the new fistulas. But main part is luckily no more so difficult to treat by endovascular surgery. They looked very, very complex, like those cases you are showing.
Yes, of course.
And one thing is, about the direct puncture of the carotid artery. This is the old way we were used to puncture the trigeminous neuralgia patients with doing alcohol injections to foramen ovale, or then later thermocoagulation.
Yes, it helped me, the neurosurgeon. One comment or question for you and for the panel is, what do you think about the radiosurgery of the fistula? In my experience, many cases very difficult to target the place of the fistula. And secondly, some of the fistula regresses spontaneous. I don't have very good opinion, or fantastic opinions, if you want, of the efficacy of the radiosurgery on the fistula. What is your think about this?
In Helsinki, after my heroic surgeries, I think the surrounding began to push the patients to radiosurgery, and they had, in some selected cases, they had good results, but they were rather small, maybe very simple cases. No, I don't think that you can treat these cases you showed. You can treat with radiosurgery. I think this is impossible. And you have to irradiate the whole brain.
Yes, but in the cavernous sinus,
I don't think so. Flow is so high. The flow is so high. So I think it is not so many.
Yes.
There are so many high flow, and it is not like in AVMs. You have selected targets and vessels which are obstructed by radiation, but not in the fistulas, I think. This is my opinion. No experience, but I told the experience in the simple dural fistulas, they react to irradiation.
Okay.
Can I make a comment?
So Altaf Ali is.
Yeah, Professor, I have a question, intriguing question. How many injuries have you encountered when you are going through from an ovale to the carotid in your career? You both being a veteran neurosurgeon and neurointerventionist, you must have seen a couple of cases. And how do you manage them?
I work at the same group. I discuss every case. I need every time the support and experience of neurosurgeon. I don't like to treat it one patient by endovascular way. She don't have a neurosurgeon close to me, not only to help me. She have a complication, not only for this, because for the experience to treat the lesion. The most difficult, or one difficult point of the endovascular philosophy of doctors is when you stop the treatment. Sometimes you need to stop a little bit and wait a second opportunity to treat the patient with another method. This is my opinion.
Luis?
Yes?
So you always treat the anterior skull-based DAVF through the venous approach?
No. This is only one case, and this is the first case I use the venous injection with onyx to learn. This is for me surgical treatment, of course.
Yeah. Okay, thank you.
Yes.
Okay, more comments, questions from anybody in the panel? Well, great. Thank you very much, Juha and Louis, and the man of many talents, Ben Zhu, who's not only participated, he televised this in China. And how many followers did we have, Ben?
More than 5,000.
Oh,
wow!
Yeah,
that's great.
Yeah,
thank you.
Because we have another SQLab Academy, also the SQLab Academy channel. I didn't check the audience. This is the only. This is the only one I translated in the channel.
That's great. Well, Juha, we're reaching the Chinese neurosurgical community. Juha.
This is thanks to Ben very many
thanks,
times. Thank you, John. Thank you, Luis. Thank you, everybody here. Thank you very much. Say ni.
Okay, do you have any topic for next week, or do you know yet, Juha, or no? You don't know?
I could repeat last week MCA aneurysms, and then we continue, because now this organization, this is good. So I speak next Friday on middle cerebral artery aneurysms.
Very good. Excellent.
Then we continue side by side. So,
okay, okay, excellent. Thanks, everybody, and we'll see you next week.
Thank you very much, everybody.
Oh, I'm sorry, Victor, you had something to say?
Congratulations for these cases that present Luis Lopez. I would like to ask some questions in private. So, Luis Lopez, could you share with me your phone number to ask you some questions in private?
Yes.
After this conference.
Yes, of course.
Yes.
In my web page, you are my phone is very easy. 34.
Excuse me. Okay.
Okay, we'll take care of it after, Victor. Okay, we're going to wrap this up now. Okay. Okay, we're going to stop recording.
Thank you. Bye.
Okay.
Bye. I send you one mail. Okay.
Okay. Yeah. Okay. We're off the air now, so you guys can communicate. I'm sure you didn't want to give the world your phone number, so you can put it in the chat. Put it in the chat, Louis. Your phone number for Victor. You want his phone number, right, Victor? Or
it's 34 609 00 609. No, sorry. 609 00 609 2699.
Thank you. Thank you so much. Bye-bye.
Wow, 5,000 people. Oh my God. Well, man, oh man.
Thank you.
You guys are rock stars. You're like musicians.
This is thanks to Subin and you. Thank you.
Yeah. So MedTion, I'm familiar with that. They're starting to do videos, huh? That's great. I wanted to show you, let me show you something. Now's my time to share. I want to show you, Dr. Ben, this conference we have on Sunday with, I don't know if you know Michael Segru. He's a neurosurgeon that works with Dr. Teo in Sydney. He's working with connectomes, and I don't even understand what he says here, but he's going to basically work about we're talking about connectomes. He's a big glioma surgeon from Oklahoma, but he's in Sydney now. And he goes to China a lot. His wife is from China. So he's going to give a talk on Sunday. And you're all welcome to come. The link is in the chat if you want to come in. And especially, I think he's going to do mostly in Chinese, but I think it's going to be dual. I think they're going to try to do both. But we're exploring the territory, and that's the way we're going to learn.
Okay, great. Thank you.
Ben, thank you very much.
Yeah.
I send you. Great. Thank you.
Okay.
Goodbye, everybody.
Bye-bye.
Thank you.
Bye.